Okay, Assalamualaikum warahmatullahi wabarakatuh, and very good morning to all the participants. Okay, welcome to the first neuro-emergency um, webinar series. Okay, the short form is news. Okay, so this is our first news for the year 2024. And then we're going to plan to have, like last year, we planned for this web series to be done every month, but there is a little bit of changes in terms of our program this year because we introduced few more academic or talk activities. Okay, so now the news will be every 3 months starting this year. Okay, so today we're going to have two speakers. One is a rheumatologist consultant, Dr. Ravathy, and then we have Dr. Chiu, endocrinologist consultant, who's going to give a talk today. So first, I would like to introduce our first speaker, Dr. Ravathy Nasadurai. She is physician and a rheumatologist in Hospital Selayang at the moment. Okay, she's graduated undergrad from Malacca Manipal College, and after that she continued to be junior doctors in a few hospitals in Pahang. She obtained her MRCP in 2015, and after that she undergo training in rheumatology from 2018 until 2021. Okay, so today she's going to give a talk about that her talk will be the title. Okay, I forgot it on top of my head. Okay, CNS emergency in rheumatology patients. Without further ado, I invite Dr. Ravathy to give her talk. Okay, silakan Dr. Ravathy.
Hi, good morning. I hope I'm loud and clear.
Yeah.
Okay. Let me open my slides first. Okay, is my slides visible?
Okay, yes.
Can. Okay, so very good morning to everyone who has joined us on this Saturday morning. And thank you to Nasrina and Dr. Iskas Yamar for inviting me to join in this first session of the Neuro Emergency webinar series. Actually, I'm not sure why I was chosen to give this topic, but Nasrina called me to give this talk on this topic. And it is quite a difficult topic to cover because when I look through a lot of papers on neuro-rheumatology emergencies, actually there's not many papers that are available on this topic, neuro-emergencies in rheumatology. So I had to do quite a bit of research, and I did the slides based on my own experience of managing neuro cases in rheumatology. So I hope this will be a beneficial talk to everyone. Okay. So when you look at central nervous system, when I had to research on what I actually needed to cover, so central nervous system basically consists of the brain as well as the spinal cord. But in interest of today's talk, I may be covering a bit more than the central nervous system, but most of my talks will be covered based on neurological systems. So what is emergency defined as? From the American Medical Association, emergency is actually classified as situations that place a life of the patient in danger or an organ function in immediate danger. So what are rheumatology patients? So these are rheumatology patients that I manage every day. A lot of you might think that rheumatology is just SLEs and rheumatoid arthritis. Actually, there's many more patients that come to us in our clinic. And if you look at it in terms of neurology and CNS, there's actually varied presentation. And through my experience from 2018 being a rheumatologist, I find that rheumatology patients can present anything, any neuro symptoms can be my rheumatology patients. So a high degree of suspicion is clinically indicated when we are managing rheumatology patients, especially when they present with neurology symptoms. Okay. So this is an extensive list of patients that I cover that rheumatologists see. So it's almost impossible for me to cover one by one diseases and their neurological presentation. So I have actually come up with a summary of today's presentation. And when you look at rheumatology emergency itself, without considering the neurological bit, most of the rheumatology emergencies that presents to the emergency department will usually present in CAPS. In APLS patients, they may come in with catastrophic antiphospholipid syndrome. It can be a variation of kidney lung syndrome in any type of connective tissue disease. And central nervous system vasculitis is one of the most relevant condition to today's topic. So anti-Rose syndrome, neonatal lupus, of course, is not considered in today's topic. And MAS also can present with neurological symptoms, especially when a patient becomes confused with MAS. Other than that, there can be scleroderma renal crisis, septic arthritis, and atlantoaxial subluxation, which all of these we will not be covering in today's talk. So when it comes to rheumatology and neurology, what is the most important thing to do when patient presents in ED, in clinic kesihatan, in any department is, first of all, we have to exclude infection. And once infection is excluded in rheumatology patients, we have to determine the origin of the autoimmune or the connective tissue disease that plays part in patients' neurological symptoms, which can either be inflammation or thrombosis. Why is it important for us to determine whether it's inflammation or thrombosis? It's because the management will vary a bit when it's thrombosis, and it will be a bit different when it's inflammation. So in emergency, I was made to understand most of the participants today are from emergency department. So the common CNS presentations that you might see in the emergency department when rheumatology patients come in, of course, the most common would be seizures. Next to it will be abnormal behavior. The next one would be hemiparesis, paraparesis, and proximal myopathy is one more emergency that is commonly seen in rheumatology patients. So to make today's session a bit more easy to understand for everyone, I am going to give a few case scenarios of the symptoms that I mentioned earlier. So let's go through the first case. So the first case, it's very easy when you know that patient is coming in with the underlying SLE, but there will be cases with patients or is already known to have the diagnosis, and some of them may just present as a new fresh case in ED. So in this case, number one is a 24-year-old lady who is known to have underlying SLE, and she is known to have SLE with lupus nephritis as well as hematological involvement. She presents to the emergency department with new onset of seizures, and patient has had 2 episodes of seizures before she presented to the emergency department. When you elicit further history, she tells you that she's been unwell for the past 2 days with frequent headaches. And she goes on to tell you that she does not have any fever, blurring of vision, or neck stiffness. Her medications were mycophenolate, 1 gram BD, hydroxychloroquine, low dose prednisolone of 5 milligrams, losartan, calcium, and calcitriol. And she claims to be compliant to her medication. So on further examination, you find that her GCS is reduced. E is 4, V4, and M5, a total of 13 over 15. Her pupils are reactive. She's afebrile. Her BP has skyrocketed to 210 over 110 millimeters mercury. Pulse rate of 90. SpO2 on a high flow mass is 98%. She appears to be confused, and other examinations are unremarkable. So at this point of time, when patient presents with seizures to the emergency department, when you consider rheumatology patients, what are the possible differentials that you could think of with this clinical history and examination? So the differentials that's possible for this patient with such high BP and seizures, a young lady with SLE and lupus nephritis, is with that high BP, intracranial bleed, or PRES, posterior reversible encephalopathy syndrome. Infarct, a meningoencephalitis is still a possibility, or cerebral lupus. The interesting thing about SLE is cerebral lupus can present as either one of these differentials: intracranial bleed, PRES, infarct, meningoencephalitis. Its form of presentation is more of an aseptic meningitis. Okay. So you go on to do a few investigations for this patient, and her full blood count reveals that she has an elevated white cell count of 21. Her kidney liver coagulation is normal. Her inflammatory markers, the ESR and CRP, is raised. Her urine FEME, there's still protein of 2+. Her CT brain and her MRI is done. Of course, in the ideal world, in the emergency setting, or even when patient is admitted to the ward, getting an MRI and MRA is quite a difficult task to do. And patient is usually just able to get a CT brain. But ideally, in rheumatology, we would really need an MRI and MRA to exclude whether this patient has vasculitis or thrombosis. After the CT brain imaging has been done, of course, LP is needed to exclude infection, because most of our patients are immunocompromised and their susceptibility to infection is very high. Okay, so in the emergency, after the CT brain was done for this patient, you can see that it is all depicted nicely with the red arrows. There is a lot of symmetrical vasogenic edema involving the white matter of the posterior cortex in most of the posterior regions of the cuttings that's obtained here in the cerebellum, the occipital, parietal, and frontal cortex. So when we go on to do an MRI for this patient, the vasogenic edema that's seen in the CT brain is better visualized in the same regions involving the posterior regions of the brain. And a diagnosis of PRES is established for this patient. So PRES is very commonly seen in most of our rheumatology patients, especially those who have SLE and those who have lupus nephritis with very difficult controlled BP. And the pathophysiology behind it can be autoimmune, or it can just be uncontrolled hypertension. So PRES was first mentioned in 1996, and patient presenting with posterior reversible encephalopathy syndrome can present with varied presentation. It can be just a simple headache, confusion, visual changes, it can be seizures, and most of these symptoms, when an imaging is done to confirm, there will be associated cerebral white matter edema seen. So when PRES is suspected and when you pick it up from CT scans, what are the possible common causes causing posterior reversible leukoencephalopathy? Is hypertensive encephalopathy, which can present in rheumatology patients because of uncontrolled hypertension when they have lupus nephritis. It can be because of acute or chronic renal disease, which also can be seen in rheumatology patients who have lupus nephritis or other form of glomerulonephritis, nephrotic syndrome. TTP, which is another entity, also could be seen in CTDs. HUS, eclampsia. We do have pregnant patients who have SLE and they also present to us with PRES, and we've managed them. Vasculitis, one of the most commonly seen changes in CT scan and in patients with SLE, PAN, or granulomatosis with polyangiitis. It could be our medications itself causing the PRES, which is IVIG, rituximab, tacrolimus, and if these patients are on these immunosuppressions, the best management is to withdraw and to observe if patient improves. Porphyria and other electrolytes abnormalities, sepsis can present as PRES, and also a post-transplant patient because they are mainly on immunosuppressants. So pathogenesis of PRES is postulated that there is cerebral autoregulation and endothelial dysfunction, resulting in the normal autoregulatory mechanism to fail, which in turn causes cerebral arteriolar pressure maintenance to be disturbed and results in hypoperfusion and extravasation of fluid in the brain, resulting in edema in the white matter of the brain. So when patient presents to press in the emergency department, what is the most important thing to do? Of course, it depends on and varies whether it's a patient with simple seizures, headache, or patients with patients who are presenting with status epilepticus. But the main aim of management is to control the hypertension as well as the seizures. And when there are medications or immunosuppressants that could cause the press itself, discontinuation of the offending agent is very important. And conditions such as pregnancy, of course, eclampsia, the management is termination of pregnancy. And when these things are done, most cases improve in few weeks, but the radiological finding will follow after months or maybe weeks later, only you can see improvement in the radiology. So in emergency setting, management of hypertension, of course, we prefer IV, either your IV labetalol or IV GTN to bring down the blood pressures. Seizures, you can load your patient with phenytoins, any anti-epileptics that's suitable and not contraindicated in that patients. And most of our patients, from my experience, that present with press, they present with status epilepticus, and most of them have to be intubated and sent to ICU. So getting a multidisciplinary approach by the anesthetic doctors, the medical team, the neurologists, and the rheumatologists is very important to ensure that patient makes it out of the press. So if BP is controlled and the seizures are not controlled after maybe 1 or 2 days of patient's presentation, what next? So as I mentioned earlier, press can be caused by autoimmune diseases like SLE, even if the BP is controlled. So in these cases, of course, your friendly rheumatologist will come in and will start on immunosuppressants based on patients' MRI findings. And also the other laboratory markers like C3, C4, your double-stranded DNAs. And we will further manage these patients with immunoglobulins, methylprednisolone, rituximab. And depending on patient severity, maybe if plasmapheresis is indicated, then even that will be brought into place for the patients. So apart from seizures, let's go to case number 2. One of the most common presentation of young patients when they come to the emergency department, especially when they have a rheumatology illness, 18-year-old girl with underlying SLE presents to the emergency department with altered behavior for the past 2 months. She was an active girl previously, and for the past 2 months, she has been very quiet and slow to response. Mother noticed that for this past 1 week, patient has been aggressive. She has been having intermittent fever for 1 week and rashes over her palms and soles. And when she presents, you go on to examine her, and her GCS shows that she has a eye component of 4, verbal of 4, and motor of 5, 13. And her BP is stable, normotensive. She's afebrile at the presentation in ED, although she has history of fever 2 days prior to presentation. And when you look at her palms and her sole, you notice very nice vasculitic lesions on the palms and on the soles. Okay, and this should alarm a high degree of suspicion whether this could be a patient with cerebral lupus. So at this point of time, the differentials for a patient who comes in mostly is psychotic because patient is aggressive already, and in some cases they could be also obtunded. Differentials for a patient who's already having SLE and on high dose steroid, we must exclude whether patient has steroid-induced psychosis, and with a history of fever, meningoencephalitis infection is one of the most well-known, notorious enemies of patients with rheumatology or immunosuppressed patients. That has to be excluded before we can further label this patient as neuropsychiatric lupus. So when further investigations are done for this patient, you notice that the white cell is elevated, her kidney and liver function is normal, her complement C3, C4 is low, her inflammatory markers are raised, her double-stranded DNA is high at 324 international units. She has a positive ribosomal P in the extractable nuclear antigen panels. And we go on to do an L lumbar puncture, and lumbar puncture excludes that this patient does not have any infection. This is very, very important because further immunosuppressing a patient with infection will result in a full-blown infection. A CT brain is done for this patient and it's normal. And in an ideal world, MRI and MRA is done at ED setting and it's suggestive of vasculitis, which makes everybody's life easier, but this is impossible to be done in a daily practice that we are in currently. So neuropsychiatric lupus is one of the most difficult presentation to conclude and say, yes, this is cerebral lupus. Why is it so difficult for rheumatologists to confirmly say that this is neuropsychiatric lupus? It's because it has a very, very presentation. As of now, high index of clinical suspicion is necessary. And this is after the high degree of clinical suspicion, laboratory and neuroimaging findings has to support the diagnosis after excluding all the other possible diagnoses that can present with a patient with abnormal behavior, either psychosis or obtundation. And so far, neuropsychiatric lupus, there's no gold standard for diagnosis, and they can present with focal or diffuse manifestations. So as I mentioned earlier, neuropsychiatric lupus, cerebral lupus, can present either in central nervous system or peripheral nervous system manifestation. It's basically any presentation at all. So that's why when we have patients with neurological symptoms, our investigation is actually extensive before we exclude and say, yes, this is neuropsychiatric lupus. So when you look at it in central nervous system, our neuropsychiatric lupus patients can come in with aseptic meningitis, acute confusional states, anxiety disorder, CVA, cognitive dysfunction, demyelinating disease, simple headaches, movement disorders, mood disorders, myelopathy, psychosis, seizures. So almost anything is neuropsychiatric lupus. So the pathogenesis is also something that's not very well established, but it's postulated that auto-affecting cerebral antibodies as well as cytokines are the possible mediators. And the vasculature in patients with neuropsychiatric lupus or with SLE itself is one of the factors that interferes with neuronal connectivity, and this results in a neuropsychiatric lupus manifestation. And as I'm repeatedly mentioning, to consider that it's neuropsychiatric lupus, all the other possible causes has to be excluded: infection, trauma, malignancy, and any other independent neurological diseases before we go on to further manage neuropsychiatric lupus. And LP is one of the things that we do to exclude infection. And in neuropsychiatric lupus, most of our patients have a normal lumbar puncture result. And sometimes you can find that the protein is elevated. What about imaging, MRIs and CT? MRIs and CT, when you go on to look at neuropsychiatric lupus, there is a varied presentation that can be seen. If patient has a small vessel disease and cerebral atrophy, your CT and MRI is different. If it's ischemic stroke, your CT and MRI is different. So patients with neuropsychiatric lupus can have cerebral atrophy, ischemic stroke, intracerebral hemorrhage, dural venous sinus thrombosis. Dural venous sinus thrombosis is one of the most common presentation, especially when patients with CTDs have a secondary antiphospholipid syndrome, or they have antiphospholipid syndrome as a primary manifestation itself. And one of the most common presentation in neuropsychiatric lupus is cerebral vasculitis. And the classical MRE angiography findings is segmental vascular narrowing, or the classical beading appearance that rheumatologists look for. So what about treatment for NPSLE? NPSLE, when it comes to ED, emergency department management, the management is mainly symptomatic. So what is expected in an emergency? Of course, if patient is having seizures, anti-epileptic. If patient is psychotic, call our friendly psychiatrist on board, get them to start the patient on some antipsychotics so that patient doesn't go on disturbing everyone around in the emergency department. And if there is a thrombosis suspected, an anticoagulation should be started early after intracranial bleed has been excluded. So when these patients are managed in the early part by emergency and referred to the rheumatologist, what do we do for patients with neuropsychiatric lupus? Of course, we immunosuppress them after infection has been excluded. And our immunosuppressants consist of high-dose corticosteroids, IV methylprednisones. And if there is infection in suspicion, we will start IV immunoglobulins. And sometimes these high-dose corticosteroids, methylprednisones, will be even topped up with IV immunoglobulins if there is some resistance and we need both of it on board. And once infections have been excluded, high-dose corticosteroids have been tried, the next one, of course, will be cyclophosphamide. And in very resistant cases, we do consider rituximab, which is a biologic. And once patient has been induced, and we are maintaining a patient with neuropsychiatric lupus, of course, other immunosuppressants like mycophenolate and azathioprine comes into place. So a lot of our patients are young. Most of our SLE patients are young girls. And some of them, unfortunately, do not have a good cognitive recovery, and they are not able to function fully after the first episode of NPSLE induction. Everything has been done. So when this happens, of course, we get most of our patients to rehab, and usually cognitive rehabilitation is able to bring them to a better functional status. Okay, moving on from neuropsychiatric lupus, let's move on to case number 3. So case number 3 is a 35-year-old lady presenting to the emergency department with sudden onset of right upper and lower limb weakness. There is associated slurring of speech, and you go on to find out that she has no known medical illness prior to this. But she also tells you that she has seen a doctor previously because she has 4 history of consecutive miscarriages previously at the first trimester itself. On examination, you find her BP to be a bit elevated, 160/90. Her GCS is full. You find that she has a bit of livido reticularis over her legs. You can see this picture here, this nice mapping that's seen on her leg. This is what we call as livido reticularis. And further examination reveals that she has slurring of speech. Her gag reflex is absent. Her lung is clear. And her motor examination reveals that she has a power over her right upper and lower limb, which is at 3/5. Investigation laboratory results reveals that her full blood count, there is a bit of thrombocytopenia, platelet is at 138. Otherwise, liver and kidney functions are normal. And her coagulation, there is a slight prolongation of APTT. Her CT brain reveals that she has ischemic stroke. And she goes on to tell you that the previous doctor that she has seen, there were some blood test results, and the doctor had mentioned that her LA was positive ×2. Her lupus anticoagulant was positive ×2 previously. It's very easy when patient tells you all these things in the emergency, but in real world, all these things doesn't happen, and we have to investigate, and results like this take some time, at least about 4 to 6 weeks before we get the results back. So when you have a easy results on presentation itself, like the lupus anticoagulant, then you can go on to conclude that this patient has antiphospholipid syndrome. So antiphospholipid syndrome is systemic autoimmune disorder, and it was initially reported in the 1985 by this person called Hughes. And it can also be called as anticardiolipin syndrome, ACL syndrome, or Hughes syndrome. It usually has vascular thrombosis. It can either present as arterial or venous. And in females, pregnancy morbidity is seen, recurrent early miscarriages or late pregnancy losses. And it should be associated with biochemical finding of persistent positivity of antiphospholipid antibodies. And the types of antiphospholipid syndrome can be primary or secondary. Primary usually is APLS by itself, and secondary is usually a result of concomitant connective tissue disease. And APLS, if you look at it, women is affected more than men. And one of the most common life-threatening condition where multi-organ thrombosis is involved is catastrophic APLS, and this is a life-threatening condition. So in patients who have antiphospholipid positive results, they can be asymptomatic carriers. They can be classified as thrombotic antiphospholipid syndrome. They can be also said as obstetric antiphospholipid syndrome. And in emergencies, they can present as catastrophic antiphospholipid syndrome. So what can patients with APLS present with? Especially in emergency, if they come in with stroke, you want to look at the other organs, whether there's involvement to exclude whether this is CAPS. They can have migraine, stroke, transient ischemic attacks. They can have pulmonary embolism. They can have a coronary artery disease, renal vein thrombosis, renal infarctions. They can have a history of recurrent early miscarriages, IUDs, IUGRs, Raynaud's phenomenon, livedo reticularis, and DVTs. So in APLS, if you look at the neurological system, patients can also have varied presentation, just like in neuropsychiatric SLE, NPSLE. So in patients with APLS, how do they present with central nervous system manifestation? It can be TIAs, it can be ischemic stroke, it can be epilepsy, it can be headache, it can be multiple sclerosis, transverse myelitis, GBS, ocular syndrome, dementia. It can be almost anything. So that's what makes rheumatology patients interesting. They can have symptoms from the top of their head to the tip of their toes. So diagnosis of APLS, in addition to having positive antiphospholipid screening of either lupus anticoagulant, anticardiolipin antibodies, or beta-2 glycoprotein antibodies, patient can have thrombotic APLS when they have vascular thrombosis, either venous or arterial in origin, or patient can have obstetric APLS when they have pregnancy morbidity, as what's mentioned here, either fetal death of more than 10 weeks or premature birth of less than 34 weeks when other causes are excluded, or 3 unexplained consecutive abortions. So when patients with APLS are suspected, of course, your antiphospholipid syndrome, lupus anticoagulant, they can come in varied presentation, but the ones that you really have to look out for is the ones with high-risk APL profile. High-risk APL profile is when your lupus anticoagulant is positive at 2 consecutive occasions, 12 weeks apart, or there's double positivity of anticardiolipin beta-2 glycoprotein, or there's triple positivity of all the antibodies itself. So these are patients that will come in with recurrent thrombosis. So according to the European Rheumatology guidelines, what is the management for patients with a definite antiphospholipid syndrome and first arterial thrombosis, like this patient that was mentioned in the case discussion just now? A treatment with vitamin K, with warfarin is recommended over treatment of low-dose aspirin only. And the INR that's accepted for patients is either between 2 to 3 or 3 to 4 is recommended, considering individuals' risk of bleeding and recurrent thrombosis. And you may consider patients to be on warfarin in combination of aspirin. with the INR target of 2 to 3. NOACs are not something that we like to use in patients with APLS, especially when they have triple antiphospholipid positivity. And there is, based on current recommendation, NOACs in patients with definite antiphospholipid syndrome and arterial events results in a high risk of recurrent thrombosis, and that's why we don't use them. And in patients with recurrent arterial thrombosis, despite adequate treatment with warfarin, increasing INR to 3 to 4 is another method to reduce the risk of recurrent thrombosis. So when patient comes in with CAPS, in combination to either low molecular weight heparin, other treatments such as glucocorticoids, heparin, plasma exchange, and IVIG is recommended. And additionally, triggering factor like infection, malignancy, and gangrene should be treated accordingly. And biologics that we use are B-cell depleters like rituximab, and in Rheumatology's center, eculizumab, which is not available in most of the centers apart from centers with hematologists. So for this young lady that presented to us, the recommended management would be physiotherapy, of course, warfarin. NOAC is not recommended. And in the event of catastrophic antiphospholipid syndrome, IV immunoglobulins, high-dose steroids, and of course, Plex and rituximab in more life-threatening condition like CAPS. So moving on to case number 4. Case number 4 is a 24-year-old Bangladeshi female who comes to the emergency department with complaints of sudden, progressive, painless vision loss in both eyes and progressive weakness in both lower limbs for the past 2 days. She also goes on to tell you that she has reduced sensation on both lower limbs. And she gives a history of arthralgia, a photosensitive skin rash, intermittent fever, oral ulceration, alopecia for the past 2 months. So this, in difference to the previous 3 cases, is not a patient with a known underlying SLE, but she comes on to give you further history of symptoms that could be symptoms of SLE. So when you further examine this patient who presents with visual disturbance and also some lower limb weakness, you find that her GCLs is full, her vitals are stable. You find that she has got nice mala rash over her face, alopecia, oral ulceration, and there's some arthritis over her small joints, including her wrists, and there's some synovitis over both her hands' wrist joint. And visual acuity is reduced to just hand movement. So in our most common cases of rheumatology, which is SLE, things that you can look out for patients who present with neurological symptoms in the emergency, be it seizures, hemiparesis, paraparesis, or intracranial bleed, or anything to relate with abnormal behavior, things additional non-neurological symptoms that you should look for is patients, whether they have oral ulcers, a classical butterfly rash, whether they have symptoms of respiratory symptoms to suggest pleuritis, pneumonitis, pulmonary embolus, pulmonary hemorrhage, whether the patient has got arthritis, whether the patient has got hair loss, whether the patient has got a difference in passing urine, whether there's hematuria, proteinuria. Okay, so these are things and clues that could lead to the diagnosis of autoimmune suspicion when patient just comes with pure neurological symptoms. So for this lady who presented to us earlier, the ophthalmologist's opinion was sought, and it was found that on fundoscopy, she had bilateral pale and swollen optic disc with fame-shaped hemorrhages, and it's highly suggestive of acute ischemic optic neuropathy. Okay, so when you further examine her motor system, you find that she has bilateral upper motor neuron type of weakness. Both lower limbs, there's reduced muscle power and brisk knee and ankle jerk reflex with plantar reflexes at extensors. And there is reduced sensation to pain, temperature, and joint position. And there's a sensory deficit up to the thoracic 8 segments of the spinal cord. Laboratory test is sent off, and there is strong positive ANA and double-stranded DNA. Patient has got low complements, and there is a positive anti-aquaporin 4 antibody for this patient as well. And the MRI goes on to show that this patient has got multiple enhancing hyperintense areas in the cervical and dorsal spinal cord with diffuse cord edema, and the other organs, the brain and the orbit, was unremarkable. So this was an image that was given for this patient, and the MRI shows that there is contrast revealed that multiple enhancing hyperintense area is seen in the cervical and dorsal spine cord with diffuse cord edema. In comparison to the A image, on B image, of course, your cord looks more edematous. So for this patient, the diagnosis that was given was a neuromyelitis optica, which is an aggressive inflammatory disorder characterized by recurrent attacks of optic neuritis and longitudinally extensive transverse myelitis. Neuromyelitis optica is one of the diagnoses that is associated with autoimmune disorders such as SLE, Sjogren's, MCTDs, vasculitis, and also myasthenia gravis. But it's quite a rare presentation, and that's not what I want to highlight today. I want to highlight more of transverse myelitis, which is more commonly seen in our patients with connective tissue disease. So acute transverse myelitis is one of the common presentation where patient has paraparesis, loss of a sensation depending on where the lesion is. So in patients with acute transverse myelitis, inflammatory spinal cord is an inflammatory spinal cord disorder characterized by acute, subacute, motor, sensory, and autonomic dysfunction. So the presentation of patient will depend on where the lesion is, where the inflammation of spinal cord takes place. If it's in the cervical, of course, most of the patient's upper and lower limb would be involved. And if it's lower down, depending on where the lesion is, patient will present accordingly. So when transverse myelitis is one of the presentation that patient comes to in emergency department, apart from connective tissue disease, other things such as demyelinating diseases like multiple sclerosis and other conditions like Adams has to be excluded. Possible other differences, of course, is bacterial, viral, parasitic, fungal infections, paraneoplastic conditions, and in autoimmune panel itself, there's multiple diseases, multiple conditions that could present as a transverse myelitis, SLE, Sjogren's, mixed connective tissue diseases, scleroderma, APLS, it can be AS, it can be vasculitis. So it's an extensive list, and workup is definitely needed. And to diagnose patient in emergency setting is definitely is something that's not possible, because the investigations of exclusion is extensive, and even when it's established that it's autoimmune, there's a whole list of diagnoses that we have to work up before we can say which is the cause of the transverse myelitis. But in general, once we have established that this patient is having transverse myelitis because of connective tissue diseases, management will again be immunosuppressants. And in acute settings, of course, methylprednisolone, IV immunoglobulin, rituximab. And once immunosuppression induction has been done, choice of immunosuppressants will, of course, be hydroxychloroquine in combination with either azathioprine or mycophenolate. And the last case that I'd like to highlight today, it may not be so much of a neurology case, but patient can have neurological symptoms when they present in ED. It's a 49-year-old female. She arrives to the ED with history of progressive generalized weakness and dysphagia to solids. So patient complains of weakness predominantly affecting the proximal upper limbs in a symmetric way. She has underlying diabetes and hypertension, and she's treated with basal bolus insulin and antihypertensives such as amlodipine and metoprolol. So on further examination of this patient, you find that her GCS is full, she's normotensive, her swallowing was weak, and you find there's lots of pooling of saliva in her mouth. On further motor examination, there's proximal upper limb weakness. Her power is only 205. Proximally, distally, her power is quite okay. She has got diffuse decreased deep tendon reflex and the proximal muscles. Otherwise, her muscle tone and sensation is normal. And other systemic examination was unremarkable. Further investigation shows that she has got a bit of a raised white cell. White cell is 16.8. Kidney function is normal. Liver function, there's slight derangement of your ALT and AST. The CK is markedly high, 1,561. And there is inflammatory markers that are raised. Your ESR is elevated, CRP is elevated. You go on to do an ECG, but there's no ischemic changes seen. So when patient comes with proximal myopathy, the list of differential is also extensive, just like all the other rheumatological conditions. When patient comes with neurological symptoms, the list of differentials is extensive. And thus, the most important thing is to exclude everything else before we narrow it down to rheumatological condition. So once drug-induced proximal myopathy, metabolic conditions, infections have been excluded, idiopathic inflammatory myopathies are one of the considerations to when it comes to proximal myopathy. So the most common condition seen is, of course, polymyositis, dermatomyositis, inclusion body myositis, and necrotizing autoimmune myopathy. Okay, so most of our inflammatory myopathies can present alone, just as myositis alone. But when it comes to dermatomyositis, there is skin disease. And when it comes to polymyositis or necrotizing autoimmune myositis, they can have interstitial lung disease. They can have malignancy coexisting depending on their myositis panel, myositis specific antibodies. So inflammatory myopathies are a heterogeneous group of subacute, chronic, and rarely acute disease of the skeletal muscles, and they commonly present as moderate to severe proximal muscle weakness and show inflammation changes on muscle biopsy. So polymyositis and dermatomyositis, they have an autoimmune pathogenesis, and inclusion body myositis, they have autoimmune plus degenerative pathogenesis, and treatment of inclusion body myositis is usually very, very difficult in comparison to polymyositis and dermatomyositis. So the things that you see, muscle weakness, muscle enzyme elevations. On muscle biopsy, there will be inflammation, and there may be extramuscular manifestation like skin involvement or interstitial lung disease. So dermatomyositis, the skin changes is very prominent. So when patients come with the presentation as mentioned earlier, look out for things like proximal muscle weakness. There may be muscle wasting if it has been a very long-standing case. There may be elevated muscle enzymes apart from your CK, the ALT, AST, aldolase, and LDH. There will be EMG abnormalities. On the hands, there may be very nice Gottron papules. Patient might have facial erythema because they are very they have a very sensitive to photosensitivity. They may have heliotrope eruption, very nicely seen over the upper eyelids. And they may have on auscultation some crepitations, which is suggestive of interstitial lung disease. So when we want to differentiate whether it's dermatomyositis, polymyositis, or inclusion body myositis causing patients' proximal myopathy, there is some difference between all the three entities. And the age of onset is usually higher in inclusion body myositis. Familial association is there in inclusion body myositis. And usually skin changes are seen in dermatomyositis, and association with other connective tissue diseases usually it's in dermatomyositis. And of course, other things, malignancies, it might be seen in polymyositis, in dermatomyositis, but not in inclusion body myositis. And ILD can be seen in dermatomyositis and polymyositis. So investigations for patients who are suspected of having inflammatory myopathies are, of course, raised inflammatory markers such as your ESR and CRP, raised creatinine kinase, your muscle enzyme, AST, ALT, LDH, aldolase, and myositis panel can be sent off. And those are myositis panel, either associated antibodies or specific antibodies. EMG can be done with the help of our neurologists. MRI of the muscles involved so that we can identify which muscle group to biopsy. When it comes to muscle biopsy, the yield is very good only when we can identify the best part for biopsy. Otherwise, diagnosis is from muscle biopsy is quite difficult if we identify the wrong muscles. That's why an MRI before a muscle biopsy is necessary so that we don't pick up the atrophied muscles, we don't pick up areas that's not actually involved in the proximal muscle weakness itself. And in a lot of patients, apart from things directing to the diagnosis of inflammatory myopathies, malignancy screening is important because concurrent with dermatomyositis, polymyositis, a coexisting malignancy should be excluded. So common myositis associated antibodies and myositis specific antibodies are listed here. So these are things that are seen quite commonly in dermatomyositis, polymyositis, and overlap syndrome. And why are these myositis specific antibodies and myositis associated antibodies important? Because they point us towards the direction. Which organ should I look for? Which organs are commonly affected? Is one of the markers that show us, oh, if anti-Me2 is positive, if NXP TIF is positive, what should I do? And which one is more associated with malignancies? Basically, the prognosis is also prognostication, and also for diagnosis of extramuscular involvement. These myositis-specific antibodies and myositis-associated antibodies is important. So again, in acute setting, our treatment is mostly immunosuppressant with high-dose steroids when infection is in suspicion or when methylprednisolone does not work alone, IV immunoglobulins, rituximab, cyclophosphamide, and when patients are already induced and improving, treatment of immunosuppression such as azathioprine, methotrexate, mycophenolate, cyclosporine, or tacrolimus is considered. Okay, here I found a very nice proximal myopathy workup when I was browsing through to prepare for the slides. And if it's possible, I think for emergency setting, this is quite good because basically the beginning part here tells you what to do when you have patients of proximal myopathy presenting in acute setting. So coming to the take-home message of my presentation today, rheumatology and neurology. Rheumatology patients can present with any neurological symptoms. And that's what makes rheumatology very interesting. They can come in as anything and everything, from tip of your head, from the top of your head to the tip of your toe. And it's important to identify the signs associated with connective tissue diseases like rashes, arthritis. And it's also important to exclude infections in other possible causes of presentation. And picking up possible life-threatening signs and prompt treatment can prevent complications. So a high degree of suspicion and proper investigations can lead to earlier diagnosis and can prevent life-threatening conditions. So that's my slides for today. Thank you.
Okay, thank you, Dr. Ravathy, for the presentations. I believe we learned quite a lot today, a lot of new things. Okay, personally, okay, the conditions that Dr. Ravathy mentioned in her presentation is some of the not rare presentation that I personally very rarely seen these cases in emergency department. But it is useful to know some of the important things that I learned from this presentation is about the general approach to rheumatology patients, where you have to exclude infections, and then you have to consider inflammations and thrombosis as the underlying problems that cause the presentations of the patients. to the emergency departments. And as you can see, there's a lot of CNS manifestations in rheumatology patients. So for me, it's one of the challenge patients to manage in ED, apart from, okay, personally, hematology patients. Rheumatology patient is one of the challenge patient to be managed in ED. Unless they present with very obvious things, okay, sometimes it's difficult to relate the presentation with the rheumatological problems. Okay, I open the floor for questions to Dr. Ravathy, if any.
Hi, Ravathy, Nasrina here.
Hi, Nasrina.
Thank you so much for your presentation. I think it covers quite the important parts of neurological manifestation in rheumatology patients, because Putrajaya is a rheumato center as well, as you know.
Yep.
Yeah, so okay, I just wanted to ask one question. You mentioned regarding steroid-induced psychosis. So can you elaborate it a little bit further? What is the dose that the patient is taking that you make it more suspicious that could it be a steroid-induced psychosis? Of course, we have to rule out other causes as well. But yeah, probably can share your opinion on that.
Okay. Steroid-induced psychosis is also a diagnosis of exclusion. Most of the things in rheumatology is diagnosis of exclusion. There is no cutoff point of a steroid dose that can tell you clearly that this is steroid-induced psychosis. Just like a neuropsychiatric lupus, you have to exclude all your other possible conditions related to the neurological problem. And once that has been excluded, of course, you narrow it down to steroid-induced and also neuropsychiatric lupus. Of course, if patient is not a patient who has had SLE with problems, not on steroids, that is easily excluded. But patients who have been on higher dose of steroids and then tapered down, then the degree of suspicion is much less. But patients who have been given high dose steroids and the psychosis worsens, then you have to have high degree of suspicion. High dose steroids, mainly prednisolone of more than 20 milligrams, higher incidence. Patients with a lower dose of steroids is a lesser incidence of steroid-induced psychosis. So basically, when you give your steroids, you find that patient is worsening and the symptoms have worsened. Patient did not have psychosis. Patient was coming in with lupus nephritis, and you started steroid and patient becomes manic or psychotic. Then you have to have high degree of suspicion if these patients have had steroid-induced psychosis. Main organs, when it's involved, our dose of steroids are high. When it's just simple things like skin, when it's just arthritis, the dose of steroids may not be as high as major organ involvement. So when there is major organ and high dose steroids of 1 milligrams per kilo is used, then higher degree of suspicion where there is a steroid-induced psychosis.
I see. Thank you so much.
All right, any more questions from the audience?
Dr. Is, can I ask one more question?
Yeah.
Okay, all right. As you mentioned that if the patient has underlying connective tissue diseases, it is a little bit more easier for us to have a high degree of suspicion that this could be a manifestation of neuropsychiatric, lupus, and many more. But most of the time, if the patient does not have that kind of underlying diseases and they come in with vague symptoms such as altered mental status, do you think ESR and CRP should be included to rule out the possibility, especially in young patients, childbearing age, as part of the workout at emergency department?
I don't think it's necessary to be included in emergency department, ESR and CRP, because as you know, apart from a marker of inflammation, is also a marker for infection. So even if it's raised, you're still unable to exclude whether this is infection or inflammation. So you go on to treat both. So for me, from my point of view, of course, there's no guidelines. ESR and CRP is not needed at emergency department to say what is the possible cause. But of course, we'll have a differentials. In emergency, to say that this patient is having an autoimmune disease, I think it's almost impossible unless there's signs that's staring at you. A beautiful butterfly rash, vasculitis, nice signs of oral ulcers, alopecia, then yes, high degree of suspicion. But I don't think the inflammation marker at that point of time is going to make any difference because you know your patient has got autoimmune disease, but you just have to exclude infection. But ESR-CRP is not going to exclude infection for you. So for me, it's not needed.
Very well. Thank you so much.
Okay.
All right. Perhaps one question from me. For the case 3, the antiphospholipid syndrome, if they presented with stroke symptom within the thrombolysis windows, is it contraindicated or indicated to start thrombolysis treatment?
I don't think thrombolysis is contraindicated. I think that if there's any neurologists here, they can correct me. But in antiphospholipid syndrome, there is no contraindication for thrombolysis treatment. As long as intracranial bleed, of course, you've done the CT scan, it's not an intracranial bleed, and you're very sure there's an infarct, there is no contraindication. But later on, of course, from the rheumatology point of view, you will not get your antiphospholipid screening done in emergency or anywhere else. It's a diagnosis that you're going to make later, unless patient is already known to have APLS. So there is no contraindication. Just treat them like a normal patient. Once the diagnosis has been established that it's a APLS, then we can start them on warfarin.
All right. Okay. All right. Thank you again, Dr. Ravathy, for the presentation that you gave just now. Okay. Thank you very much. Now we're going to move on to our next speaker, Dr. Chew Ken Seng. Okay.
Dr. Is, wait, let me
okay.
start a new recording.
All right. Okay.